Welcome to the USMLE question and answer blitz. We are diving into a high yield questions. Remember, in the exam, you get 90 seconds per question in a 60-minute block covering 40 USMLE questions. Get your coffee. Let's nail this case and keep rocking our 40 question block. All right, let's do this. Let's look at this clinical case. A 30-year-old woman presents with fatigue, jaundice, itching, and pale stools. Symptoms that have developed over the past few months. She also reports shortness of breath and has a dry cough. Her history includes recurrent respiratory infections, and her mother was diagnosed with COPD at a very young age. On physical exam, she is jaundiced, has petechiae, hepatomegaly, and tenderness in the right upper quadrant. Auscultation reveals wheezing and decreased breath sounds. A chest X-ray shows pan-SNR emphysema. Her vital signs are mostly stable, except for mild tachycardia. Now, based on this presentation, we are asked to identify the most characteristic liver histopathology. The key clue here is the combination of liver disease and pan-SNR emphysema in a young non-smoker, which could raise immediate suspicion for alpha-1 antitrypsin deficiency. All right, the correct answer is A. PAS positive, diastase-resistant granules in hepatocytes. In alpha-1 antitrypsin deficiency, a mutated version of AAT protein is misfolded and gets trapped in hepatocytes. These misfolded proteins accumulate as cytoplasmic inclusions that stain positive with periodic acid Schiff, or PAS, and are resistant to diastase, which is used to digest glycogen. This makes the diagnosis pathologically distinct. The lung disease in AAT deficiency presents as pan-SNR emphysema, which typically affects the lower lobes and can occur even in non-smokers. This is due to uninhibited neutrophil elastase activity in the absence of functional AAT. Let's quickly review the incorrect choices. B. Perisinusoidal fibrosis is more common in venous outflow obstruction or cirrhosis, not in AAT deficiency. C. Feathery degeneration is associated with bile stasis or cholestasis, often seen in conditions like primary biliary cholangitis. D. Prussian blue positivity indicates iron overload. Think about hemochromatosis. E. Congo red stain is usually identify amyloid, which doesn't fit this case. So again, the hallmark here is that PAS positive diastase-resistant globules in hepatocyte point us towards the AAT deficiency. To summarize, alpha-1 antitrypsin deficiency is a genetic disorder that affects both the lungs and the liver. In the lungs, it leads to pan-SNR emphysema, especially in the lower lobes, due to the destruction of alveolar walls from unchecked neutrophil elastase activity. In the liver, the misfolded AAT protein accumulates within hepatocytes, leading to inflammation, hepatomegaly, and eventually cirrhosis. Histologically, the defining feature is PAS positive diastase resistance inclusions in the hepatocyte. This